Dr. John Snider. He was born and raised in Virginia and then voluntarily came here for schooling to receive his medical school education. He completed his neurology residency here at the University of Michigan, and he is in his second year of fellowship as a movement disorders fellow here with us. And he has strong interests in the treatment of movement disorders and medical education, and I think you'll find him a wonderful speaker. So let's welcome Dr. John Snider.
Thank you again for coming today. I'll be talking about Parkinson's disease, basically all of it, in kind of a condensed form. I have no relevant financial disclosures. I'll be giving you kind of a broad overview of Parkinson's, some background on it, symptoms, both movement and non-movement symptoms, how it's diagnosed, and how we treat it, again, through the movement symptoms, the non-movement symptoms, and some more recent therapies that have been FDA approved as well. Start with a little bit of background. So what is Parkinson's disease? It is a chronic condition. It is something that once you get it, it stays with you long term. It's progressive. It gradually gets worse with time, does gradually progress with time. It's what we call a neurodegenerative disease, which means parts of the brain die over time, and those brain cells that die then result in the disease that we see. And it's characterized by a loss of the movement chemical dopamine in a part of the brain called the substantia nigra. If you look at the picture there on the right, there's a dark streak here that's the substantia nigra with dopamine cells, very healthy in a normal person. And over here, you lose those dopamine cells in the substantia nigra. You don't have that dark streak anymore. 1 out of 1,000 people have it. And if you look at people who are older than 65, 1 out of 100 people have this. We're still working out the specific cause, why some people get it, why some people don't. That's an active area of research. Most cases are not hereditary, which is to say they're not passed down by family members from mom or dad to son or daughter, although there are minority cases that are hereditary in nature. In terms of the symptoms of it, I'll talk about the movement symptoms first. And when we talk about the movement symptoms of Parkinson's disease, we often will use the phrase Parkinsonism. Parkinsonism are the movement symptoms that can be seen in Parkinson's disease or one of its mimics. The classic movement symptoms, one is bradykinesia, which just means less movement, lack of movement, smallness, slowness of movement. The second is rigidity or stiffness. The third is a tremor at rest, and I contrast that with a tremor when you're doing things, which is an action tremor. A tremor at rest is more when you're relaxed, not paying attention, when your muscles are relaxed. And then also imbalance, gait instability. These are the cardinal features of Parkinson's, the cardinal movement symptoms. How this may present on a day-to-day basis for patients who have Parkinson's disease. I'm just going to bring these all out. For bradykinesia, again, the less movement, the smallness or slowness, you may note shuffling or slowness of gait, smaller step, the more stooped posture. Your handwriting may get smaller with time. Your voice may get softer. You may have trouble with excess saliva or drooling because you're not swallowing as much. Again, less movement. Your face may become less expressive. Relatives or friends may comment that you just aren't as expressive with your face. That's the classic mask-like faces that you may hear about. There may be some decreased arm swinging when you walk. A very common complaint is a feeling of weakness, and then when your doctor examines you, we see that the strength is actually quite good, but it's that feeling of weakness that's likely due to things aren't moving as fast as they normally would, and that contributes to this sense of generalized weakness. In terms of the stiffness and the rigidity, you may just feel stiff. You may have trouble getting up from low car seats or soft chairs, trouble buttoning buttons, zipping zippers, trouble turning over in bed, again, due to the stiffness. In terms of the tremor at rest, you most likely notice it if you're sitting on a couch, watching TV, kind of relaxed with your hands in your lap. And then obviously with imbalance, trouble maintaining balance or falls, more stumbling, feeling unstable on your feet. There's also non-motor symptoms. These are the non-movement symptoms. These are often the quote-unquote invisible symptoms of Parkinson's, the ones that aren't quite as easily apparent to someone just looking at you. Choking on fluid or slurring of speech. Autonomic symptoms, things like lightheadedness when you stand up, trouble emptying your bladder, trouble with constipation, erectile dysfunction. a loss of sense of smell that often comes actually quite early in the disease in many patients. We think that may actually be a precursor in many cases to the other motor symptoms. Memory problems may develop, hallucinations possibly over time. Mood changes. People with Parkinson's are much more likely to have depression or anxiety or just apathy, just not wanting to do things, kind of the lump on the log type feeling. Fatigue, a very common symptom of Parkinson's. Pain, dream reenactment, punching, kicking, running in your sleep, yelling out, screaming in your sleep. And sleep apnea. Your airway closes off when you sleep, and then you open it back up again. It doesn't wake you up, but it can pull you out of sleep, and that can contribute to symptoms. Now, one thing I stress with these non-motor symptoms, everyone with Parkinson's disease is different. It doesn't mean that if you have Parkinson's, you're going to get all these symptoms. These are just possible symptoms you may get, and we like to keep an eye on just in case you do get them, because we can often help with these symptoms. In terms of how Parkinson's disease is diagnosed, the only definitive diagnosis is through autopsy, and brain tissue will show characteristic patterns of Parkinson's disease. I usually don't recommend that on first line the first time I meet a patient. We have other ways of sorting this out, fortunately. Practically speaking, though, the diagnosis really is it's clinical, which means it's made by hearing the patient's story, by doing an exam. Usually it's diagnosed by a neurologist or a movement disorder specialist. A practical definition of Parkinson's disease that I often use is you have motor symptoms of Parkinson's, the movement symptoms. You have a significant response to adequate doses of carbidopa, levodopa, Sinemet, dopamine replacement, or one of its similar agents for at least a period of time. And we don't see evidence of one of the Parkinson's disease mimic conditions, the Parkinson's plus conditions as we sometimes call them. In terms of additional testing, are there additional labs or studies that you need to diagnose it? Not required. Other workup is not routinely required or ordered to diagnose Parkinson's. It is a clinical diagnosis, unless there's some atypical symptoms, symptoms that don't quite fit or that would make us more concerned that something else is going on or one of the mimics may be going on. Then we may consider additional testing. But usually you don't need additional lab work or imaging. It's a clinical diagnosis. A quick word about the Parkinson's plus syndromes, the mimics. They're called this because they're Parkinson's plus because it's Parkinsonism, the movement symptoms of Parkinson's, plus something else. And this is, the plus something else is usually what brings people to clinical attention. So for example, Lewy body dementia, you get Parkinsonism, the movement symptoms, plus early memory problems, usually associated with visual hallucinations and fluctuations in attention. Now, people can get memory problems as Parkinson's disease goes along, but if we saw very early severe memory problems, it may make us think that it's one of these mimics, such as Lewy body dementia. Another mimic, progressive supranuclear palsy, PSP. This is Parkinsonism plus very early profound gait problems, falling problems, very early in the disease, very severe. Oftentimes with specific eye movement abnormalities that your neurologist would look for on exam. Multiple systems atrophy, MSA, another mimic, Parkinsonism, plus very early and severe autonomic problems. Every time you stand up, your blood pressure drops like a rock and you pass right out. Severe urinary retention or constipation, severe erectile dysfunction, maybe also with coordination problems. Again, people can have these symptoms as Parkinson's progresses, but if we saw these symptoms very early and very severe, it does raise our antenna, could this be one of the mimics? And then something also worth noting, medication-induced Parkinsonism. This is when we see someone who looks to all the world like they have Parkinson's disease, but we also see they're on a medication, such as an antipsychotic or anti-nausea medication that is blocking dopamine and is effectively causing medication-induced Parkinsonism. And we stop the medication, and oftentimes that can improve symptoms. So again, these mimics that, just in case you hear about them, these are not Parkinson's disease, but they can look a lot like them. In terms of the treatment of Parkinson's disease, so we'll start again with the kind of a feeling of the general course of the disease. And again, no two Parkinson's patients are alike. It's different for everyone. But generally speaking, again, there's no crystal ball for how fast or slow it will progress or what symptoms people will get. Everyone's unique. It is a chronic and slowly progressive disease. This is not something that changes overnight. This is something that is gradually progressive. It's not a fatal condition. You don't die of Parkinson's per se, in the same way that you don't die of diabetes. but it can contribute to a variety of symptoms which can worsen and complicate health, and this kind of complications must be dealt with. We don't have anything right this second that's going to slow the disease, reverse the disease, stop the course. We have symptomatic treatments, so if the symptoms bug you, we can help treat the symptoms, but we don't have anything right at this second that's going to reverse or slow down the disease or undo the damage. It's an active area of research, obviously, but at this time, we don't have that option. And because treatment is symptomatic, if the symptoms bug you, we treat it. If the symptoms don't bug you, we keep an eye on things. The focus of treatment really should be on improving day-to-day functioning. What do you want to do that you can't do as well or you can't do at all, and how can we improve that so you can go about living your life, doing your day-to-day things? Again, our goal being to keep you as independent and safe as possible for as long as possible. The general course of treatment, again, different for everyone. There's often a kind of a honeymoon period of excellent motor control for years at a relatively low dose of medications. Gradually, the medications do become less effective. They may last for shorter periods of time. You may get more of this off time. So off time is times during the day when your symptoms are not well controlled versus on time, which are the times of the day when your symptoms are well controlled. So you may get more times during the day when your symptoms are not well controlled. Those times may be more unpredictable when they're going to occur. Again, this is not due, and I'll touch on this in a little while, it's not due to the fact that your medication is not working or stopped working by itself. It's just that the disease is progressing with time. You may over time require escalating doses of medication. You may have more symptoms that get in the way of your day-to-day functioning. More times during the day when your symptoms are not well controlled. You may develop the fidgety, wiggly movements as a side effect of the medications. And the non-movement symptoms may become more prominent over time and more difficult to control. Again, I don't want to paint a doom and gloom picture here. People usually do well over time, and these are just, this is how some of the symptoms could develop over time. But again, the point of this is, very close attention needs to be paid over time because the disease can get more complicated the longer you have it and needs close attention. Questions that will guide a neurologist's treatment of the disease. The biggest thing is, are you happy with the level of symptom control? I say a happy patient is a happy neurologist. If you're happy with your level of control, I'm probably not going to be doing a whole lot to change things because you're functioning the way you want to function. I warn patients not to aim for perfection. We often don't get 100% back to the way you were before the disease, but we aim for satisfaction. If you're happy with your level of control, maybe you have a little bit of tremor, maybe you're a little stiff, but gosh, I can do what I want to do, and I'd like to kind of hold the fort here. That's very reasonable. And a lot of times these decisions are they are always very patient-centered, patient-driven, how the patient feels they're doing. We often want to know in what ways you're limited. Are the medications effective enough? Are they lasting long enough? Are you having side effects? And then one thing I'm going to touch on in a little more depth is, are you having the dyskinesias? These are the fidgety, wiggly movements like Michael J. Fox had that can be a side effect of the medications. And also, are these movements bothersome to the patient? And I underline that because patients can often get dyskinesias, fidgety, wiggly movements, and it doesn't bother them. It doesn't get in the way of their functioning. Yeah, they're wiggling, but it doesn't bother them. It may bother the family. The family may be a bit freaked out, but the patients are like, yeah, I'm happy with this. My symptoms are well controlled. No problem. So it's important, are the wiggling motions bothersome or limiting to the patient in terms of whether we just observe them or whether we need to do something to treat them. This is a rather extreme example of the fidgety, wiggly movements. Again, these are dyskinesias. They could be oftentimes much more subtle than this. They may just look like someone being a little restless, a little fidgety. Again, this kind of sense of just kind of like almost ants in the pants, fidgety, wiggly, restlessness, discomfort, looks uncomfortable, but doesn't necessarily mean it is. One thing I want to stress to patients is, so these dyskinesias are very different than your rest tremor. And we treat rest tremor versus dyskinesias very differently. So it's important your doctor knows if you say my shaking's getting worse or my movements are getting worse, do you mean the dyskinesias, the wiggly, fidgety movements often associated with timing with when you take your medication? Those are getting worse, or is it that your rest tremor is getting worse? And being able to differentiate those two to your doctor is important in terms of how we deal with it and treat it. Again, many patients can go many years without developing dyskinesias. For those who do develop them, we have good options to treat them, and many times the dyskinesias themselves are not overly bothersome too. In terms of treatment, for the movement symptoms, we have a number of options that are all important: medications, exercise, possibility of surgery, and I'll talk about that, and I'll also discuss some of the new FDA-approved treatments as well. So when it comes to medications, I think we at University of Michigan, and I think really on a national and international level, are really realizing that carbidopa, levodopa, Sinemet really is the best option we have. It's an oldie but a goodie. It's been around for ages, and it really does the job well. It's basically dopamine replacement. You don't have enough dopamine in your brain, we're replacing it with this dopamine supplement. The levodopa is basically the dopamine. The carbidopa is the stuff that keeps the dopamine where it should be in your brain and not elsewhere in your body where it could cause more side effects. It's basically the most effective and well-tolerated drug we have for controlling the movement symptoms. And I think there's a strong argument that could be made to usually start with this medication for treatment. Possible side effects: over time you can develop dyskinesias as a side effect. Again, this is a side effect of the medication itself. If you were to stop the medication, the dyskinesias would go away. People can get nausea or GI upset with Sinemet. People can sometimes get confusion or sleepiness, and if they're more prone to memory problems or hallucinations, it could provoke hallucinations. And sometimes people will note lightheadedness, particularly on standing on this medication. Again, these are side effects we can often work around, but are things to be aware of. Despite these possible side effects, it's still better tolerated than the other Parkinson's medications for the most part. Some people may say to take it on an empty stomach because it's absorbed better. I'm often keen on telling people to take it with meals. It may absorb a little less well, but it often can be much more tolerated from a nausea GI standpoint. If you're tolerating it well on an empty stomach, that's fine, but certainly if you're having any issues with nausea or GI upset, having it with some food can be a good way of tolerating it. I will warn people, usually don't take it right before bed because you're going to sleep through the symptomatic benefit. Remember, this is a symptomatic medication to help the movement symptoms. I also want to stress being consistent with the timing is important, both for keeping a regular schedule through the day and making it easier for your doctors to know how to adjust things to better control your symptoms. A few other words on carbidopa, levodopa. It best helps with the smallness, slowness, the rigidness, and the rest tremor to a slightly lesser extent. It really doesn't help a whole lot with balance or falls. It sometimes can help with freezing, sometimes not, and it doesn't do anything for the non-movement symptoms that we talked about: depression, fatigue, memory problems. It really is for the movement issues themselves. Some myths, and again, these are false things that until actually very recently, many patients and really doctors believe these are myths. There's myths that Sinemet Carbidopa, levodopa has more side effects and is less well tolerated than other Parkinson's medications. I think there's good data out there now that actually is better tolerated than many of the other medications. There's a myth that it wears off the more you use it. Once you start taking it, there's a timer that's started, and when that timer wears off, it's not going to work as well. That's not correct. This idea that you got to save it till the very end to really make it count, that's been shown to really not be correct. The disease progresses with time, so the medication becomes less effective with time because the disease progresses, but it's not that if you start the medication earlier, there's a set timer that then starts. That is how long it's going to work. There's a myth that it will make Parkinson's worse in the long run. That's not true either. It does not make things worse in the long run, whether you take it or whether you don't. Some facts that kind of echo that. Again, it's the best tolerated and I think most effective treatment for the movement symptoms, both in the short and long term. It doesn't wear off the more it's used in the sense that the medication doesn't become less effective. It's just the disease progresses and you need more medication because the disease is farther along. In the same way, someone with diabetes may need more blood sugar medication control as the disease progresses. Taking it early, again, does not result in worse long-term symptoms. There's no harm in starting it early as a first-line treatment, and I don't think there's a compelling reason to delay. In fact, if anything, having better control for more years, I think, is a definite incentive to have it on board. It's definitely more cost-effective. Some of the other Parkinson's medications can be quite expensive. And again, I think it overall results in better control in the long run. Now, that's not to say that if someone started you on a different Parkinson's medication that they're wrong or that that's an incorrect choice, but I just think that there's more and more evidence that carbidopa, levodopa is a really excellent first-line choice. And many neurologists you may talk to may not realize that. I think that's information we're still trying to get out as well, so I want to make sure you all are aware. There's additional agents that can be used for Parkinson's. These are what we call kind of adjunctive agents, agents that we tend to use in addition to the carbidopa, levodopa, if we need a little more oomph. Dopamine agonists like pramipexole, ropinirole, rotigotine do have potential side effects, greater chance for worsening memory or hallucinations. I do see a greater chance of kind of disinhibited behavior, so patients going out and spending their life savings gambling or buying silly things. Patients who actually get very hypersexual and that becomes very frustrating for their spouse. I've seen patients empty out their bank accounts on this medication. Again, not to scare you to think this is a terrifying medication. It can be very helpful. It just means you have to keep an eye on these things when you're on it. Sleep attacks, another potential system as well. People can be driving along and all of a sudden they just conk out, or they have an overwhelming fatigue and they have to conk out. That can be very dangerous as well. Again, just symptoms to be aware of, to monitor, and if you have these, you should let your doctor know. The Maobi inhibitors like selegiline or rasagiline are quite expensive. Theoretically, there could be a risk if you're also on an antidepressant and you take those. Certainly needs to be closely monitored if you're on both. Entacapone, also called Comptan, is really good for giving you an extra 30 minutes or so of on time per dose. It makes the Sinemet, the carbidopa, levodopa, last a little bit longer, basically. It doesn't work by itself, though, so it needs to be given with the Sinemet. And of course, it can worsen any side effects that Sinemet may cause, too. And finally, amantadine can be a very helpful medication for dyskinesias, the wiggly, fidgety movements. It may slightly help with tremor, probably not a whole lot, but mainly is used if you get very wiggly, fidgety as well. Not great if you have significant memory problems. I'm going to make a quick note about anticholinergics, one in particular, trihexyphenidyl, also called Artane. Generally speaking, and this is a generality, we don't recommend it for Parkinson's disease due to a lot of potential side effects and the fact that it really only helps with tremor. It doesn't really help with the other Parkinson's symptoms. I have many patients who are on this or come in to me as second opinion. We take them off it and they say, wow, I feel so much better being off this medication. We really only use it kind of as a second line, third line, fourth line treatment for refractory rest tremor. Again, it has its place, but it's something that I warn people should not be a first-line agent for most patients, and it should be used with caution. I'm going to switch focus from the medications to exercise, which in my mind is as important as any medication we can ever give people with Parkinson's. Everyone with Parkinson's disease should be involved in scheduled, safe exercise. Study after study after study have shown it's as good as anything we can prescribe. There's even some data that it may provide some neuroprotection, brain protection from Parkinson's. Whatever you enjoy doing that gets you moving on a regular basis, do that. There's not one that's better than the other. There's been great data showing things like this list here: walking, biking, boxing, dancing, tai chi, yoga. Whatever you enjoy and gets you moving, do that and do it regularly. The patients who exercise do so much better in the short and long term compared to those who don't. There's actually convincing data coming out now that even day-to-day household activities, going around and cleaning up around the house, doing some gardening, washing the windows, even those little activities during the day can also provide significant day-to-day benefit. So, anything you can do to kind of get up and do things can provide incredible benefit for you. Additional therapies as needed, to know that they're out there. Physical therapy or occupational therapy can be very helpful. They can work with you, particularly for walking, gait retraining, strengthening in the legs, balance. I do say have a low threshold to ask your doctor about these. Don't wait till you start falling left and right to ask about it. If you're feeling unstable on your feet, or if you have trouble doing day-to-day activities, this may be quite beneficial for you. They can do that locally. You don't have to come to a major medical institution in order to get that either. Sometimes they can even do it out of your house if you're particularly infirmed. There's an aspect of it called LSVT big and loud therapy. This is intensive physical and speech therapy focused more on getting around the bradykinesia, the smallness, the slowness. So they teach you to swing your arms bigger, to walk bigger, to talk louder, so that the smallness of movement is less of a problem. It's a little more intensive therapy. The big portion is through physical therapy. The loud portion is through speech and language therapy. You want to make sure your therapists are certified in this, and there's a website I put on there that you can search for therapists in your area who are certified in that. And you just get a prescription from your doctor and do that. Speech and language therapy can be quite helpful in and of itself, helpful for speaking problems, slurring of speech problems, swallowing problems, can be very helpful to be evaluated there as well. Social work, I put a big plug in there. They're very helpful for so many domains. If additional resources or assistance are needed, emotional support for the family, for the patient, if there's issues at home, whatever, if things aren't going the way you want them to, these are wonderful people to talk with, and I highly recommend having them involved. Other things, if you're worried about safety at home, falls at home, they can do safety evaluations, where to put up some bars or watch out for loose rugs, just ways to make things safer. And if there's any concern for driving, and either from the patient or from the family, again, focus on safety in Parkinson's. If there's any concern that you could use some tuning up on your driving or a little brushing up, there can be some driving safety evaluations. If you get them through a local institution, they're not going to cut up your license. They're just going to see how you're doing, give you some tips and tricks, and kind of go from there. So that can be helpful as well. Other treatments, deep brain stimulation, is basically you put electrodes in the brain. You can see here there's an electrode going deep into the brain. It's then connected to a wire that comes down underneath the skin, all underneath the skin, to kind of a pacemaker battery in your chest, again, underneath the skin. And it administers electrical pulses. You don't feel it pulsing in you, but it administers electrical pulses that can improve the movement symptoms, the motor symptoms of Parkinson's. What does it do? It can improve the motor symptoms, particularly the off time, the times during the day when you're not getting good control. It can make it more predictable. It can increase the amount of time during the day that you have good symptom control. It'll only provide as much benefit as the best response to Sinemet, Carbidopa, levodopa. If you have a symptom that has had no response to Sinemet, deep brain stimulation is not going to help with that. I really think of deep brain stimulation kind of as electrical Sinemet, basically. Deep brain stimulation can reduce your medication requirements. It usually doesn't eliminate them. You're beyond some small, potentially small dose of medication, but it can reduce how much you need. And it can certainly be very helpful for the dyskinesias, the wiggly, fidgety movements, if those are bothersome. What it doesn't do, deep brain stimulation does not alter the course of the disease. It does not slow it down. It does not reverse it. It does not stop it. It doesn't help with the non-movement symptoms, speech problems, thinking problems, lightheadedness problems, mood, depression. Doesn't help with those, and in some cases it could worsen them a bit. And that's why when we're considering deep brain stimulation for people, we see if those issues are already problematic, because we don't want to make something that's bad significantly worse to a way that it would impair you. And again, it doesn't improve anything that hasn't been helped by Sinemet, Carbidopa, levodopa, with the one exception of rest tremor. It can help a bit with rest tremor, even if that's refractory to the medications. When you should consider deep brain stimulation, it's not something that we recommend right off the bat because there is risk with any surgery, and if you can get good control of symptoms with medication, why take the risk right off the bat? We considered in people who have a clear diagnosis of Parkinson's disease who've responded well at some point to carbidopa, levodopa, with movement symptoms that are getting in the way of your day-to-day life, who we've tried all the good oral medication therapies and that's just not cutting it, who don't have significant like dementia or uncontrolled depression or mood symptoms. Again, we don't want to worsen those with surgery. There is risk with surgery. With this, it varies a little institution to institution, but a reasonable number to quote is there's a 3% risk with surgery that you could have stroke, bleed, infection, or some problem with the actual equipment that requires replacement. Again, 97% chance that it's going to be worthwhile, but that's not an insignificant risk, and it's not something we jump people into unless their symptoms really have failed everything else and they really are impaired by this. And it's, again, a very patient-centered decision about whether to go through with it or not. Again, there is some chance it can worsen to some extent thinking, speech, and mood and balance as well. So again, there could be some trade-offs as well. A word on a couple of new FDA-approved therapies. These are mainly used more in advanced disease or special circumstances. These are not first-line things that we throw out there. First is a new, basically long-acting Sinemet called Rytary, and you may have already heard about Sinemet Carbidopa levodopa CR, which is kind of a sort of long-acting, but this is a really true long-acting Sinemet. It increases the on time, the time during the day when your symptoms are well controlled, by about 1 or 2 hours. So it gives you an extra 1 or 2 hours a day of symptom control compared to Sinemet. It's best used for people who have significant kind of off times and when the other medications just aren't cutting it anymore. These are the types of patients who are probably approaching consideration for deep brain stimulation surgery anyway, but this can also be a helpful medication to buy you a couple more hours during the day of better symptom control. It has the same side effects as Sinemet, carbidopa, levodopa. It is quite expensive, so that it's a new medication. It's fancy, sparkly, so keep that in mind. Another new FDA-approved treatment is the Duopa intestinal gel pump. We're basically pumping carbidopa, levodopa directly into your gut at all times. A continuous infusion through a small tube that comes into your intestine. Similar to the Rytary, it probably gives you a couple extra hours of good symptom control during the day. It's pretty safe, and it's probably a reasonable option if you're maybe not quite at the deep brain stimulation standpoint yet, but you're wondering if you could maybe do a less invasive option for some better control, or maybe you're not a deep brain stimulation candidate, and this could be a less invasive option for a little better control. Most people do have some minor surgical side effects in the first few weeks, so you got to make sure you're at a center who has people who can respond to you if you have side effects or tube problems or this or that. Again, special circumstance for people who have more advanced disease, who are kind of more on the cusp of the deep brain stimulation consideration side. Talking about the non-motor symptoms, the non-movement symptoms, and I kind of have the tip of the iceberg picture there because oftentimes when the movement symptoms are well controlled, we look at someone and say, oh, you're not tremoring anymore, you're not stiff anymore, things must be going great for you, you're just fantastic. And they don't see these invisible symptoms, these other symptoms that can be just as debilitating, just as bothersome, if not more, but that you may not notice unless your doctor asks about them, unless you volunteer them. So these are just as important as any movement symptoms in Parkinson's. These are the ones I'm going to talk about. The memory problems and dementia, as well as the fatigue, will be discussed in detail at later lectures, so I'll hold off on those ones. Let's talk about some of the other non-movement symptoms. So depression and anxiety, very common in Parkinson's disease. Classic symptoms of depression: feeling sad or down, losing interest in things, just not wanting to do things. I contrast that a little with the apathy in Parkinson's, which can be a little different. Apathy, kind of lump on a log, but still interested, still upbeat. With depression, feeling sad or down, maybe you're not sleeping as much, or maybe you're sleeping way too much. Maybe your appetite isn't very good, or maybe your appetite is way too much. Maybe you feel like your concentration, your memory, your energy is low. Again, these are somewhat non-specific symptoms. There's a lot of things that can cause these, but if you say to yourself, gosh, I'm having these symptoms, this may be some depression that may be worth looking into treating. Treatment can include medications for antidepressants, but just as importantly, talk therapy, talking to a therapist, counselor, social worker, maybe seeing geriatric psychiatry who are specialized in depression in patients who are older, who have Parkinson's disease, can be quite helpful, quite effective, quite useful. I do note that sometimes people have some depression associated with the wearing off of their medications. At the end of their Sinemet dose, when their symptoms get bad, they feel really down in the dumps. Then they take their medication, they feel very upbeat, and they're feeling great. With that, we treat it a little bit more that it's a wearing off phenomenon. It's a more Parkinson's motor symptom phenomenon, versus people who just feel down pretty much all the time, or most of the time, we think more depression. So be aware of that, keep an eye on that. Hallucinations can be seen in patients who have long-standing Parkinson's disease. It can also be a side effect sometimes of some of the Parkinson's medications. So if you start a new medication or you crank up the dose and you start seeing visual hallucinations, things that aren't there, hearing things that aren't there, you want to let your doctor know. One important question for patients who have this, particularly in the long term, is how bad are they? If you occasionally see a small child who's really cute and he's standing there and you say, hi, and that's about it. It's not scary, it's not bothersome, it's not disruptive. You may say, well, let's just keep an eye on things, and if it starts to get disruptive, if it starts to get scary, then there's treatment options there. Or maybe adjust medications. But if it's non-bothersome or rare, we may opt to keep an eye on it. The best medications to treat hallucinations. I mentioned earlier that most antipsychotics can actually cause Parkinson's disease because they block dopamine, which you already are low on in Parkinson's. There's a couple medications that don't really block dopamine but can still help with hallucinations. Clozapine is a very effective one. It's a pain to monitor, though. You need to get blood draws very frequently because of the potential risk that it can make your blood counts come down. So if you start this medication, you're going to be getting blood draws on a pretty regular basis, certainly initially, and even in the long term as they space it out some. Another one, quetiapine, Seroquel, may be helpful. But again, the point here is you want to avoid the normal antipsychotics because that's going to make the Parkinson's way worse. Again, I specify that again. Your doctor should know not to give you the other normal antipsychotics if at all humanly possible because that's going to worsen the Parkinson's because it's going to block your dopamine and you need every bit of dopamine you can get. Some patients may benefit from a memory medication. Sometimes that helps hallucinations as well. Having geriatric psychiatry again involved could be very helpful. There are pros at dealing with this. And you may need to consider going down on your Parkinson's medications because again, the Parkinson's medications can worsen hallucinations. It's a balance. Moving forward, some other non-movement symptoms of Parkinson's disease. So the REM sleep behavior disorder, which is kind of the dream reenactment, kicking, punching, running in your sleep. If it's infrequent, if it's mild, you can just keep an eye on it. If it's more bothersome, you're falling out of bed, you're throwing yourself at a wall, you're punching or kicking your spouse is having to sleep in another room because of this, that's when you want to consider treatment. We have very safe, very reasonable treatments for it. You can try some melatonin before bed. That's actually been shown. It's an all-natural vitamin, basically. It's in everyone's body. Regulates sleep cycles. Can be very helpful. If that doesn't do it, a low dose of clonazepam, Klonopin, before bed can also be very helpful in quieting those down to make it so it's not dangerous or bothersome. People who have REM sleep behavior disorder and Parkinson's are certainly at increased risk for that sleep apnea that I mentioned earlier. People who have untreated sleep apnea, it can increase the risk of depression, memory problems, lightheadedness, having to go to the bathroom a bunch of times at night, fatigue during the day, sleepiness during the day. In the long run, it can increase your risk of stroke or heart attacks. The point is, if you have sleep apnea, it's really worth your time to get it diagnosed and treated because it can provide all sorts of symptomatic benefit if you treat it. Insomnia, what to do about that, can be due to a lot of causes, but generally one of the first things we look at is good sleep hygiene. Try to avoid taking a bunch of naps during the day. Don't watch TV or do anything exciting right before bed. Try to keep the lights low at night, not really bright. Try to tell your body it's time to go to bed. Don't drink nighttime caffeine. Avoid stressful activities. If you have underlying depression or anxiety, that can certainly, one of its cardinal features is trouble sleeping, so getting that treated can be important. If you have issues sleeping because you're really stiff or your Parkinson's symptoms are not well controlled, then working to control the nighttime Parkinson's symptoms is worthwhile. If you have frequent urination at night, talking to your primary care doctor to see if they can help you with that can be useful. You may consider some prescription sleep aids. And if it's really refractory, a sleep clinic can actually be quite helpful in this as well, as can looking for sleep apnea, which could also be contributing. We talked about some of the autonomic problems, the blood pressure problems. When you stand up, your blood pressure drops, you feel lightheaded. First, second, and third treatment for this, plenty of fluids, salt your food. Again, obviously if you have heart problems or another reason to limit this, you want to let your doctor know. But generally speaking, staying well hydrated with water, sugar-free Gatorade, that sort of thing is important. Coffee doesn't quite count, that can dehydrate you. Soda doesn't quite count, that can dehydrate you. But staying hydrated, salting your food a bit can be very useful. Obviously, taking your time, going from lying to sitting, sitting to standing, particularly first thing in the morning or overnight. Working with your primary care doctor, people with Parkinson's in the long run may actually need their blood pressure medications weaned down over time because they're getting this lightheadedness on standing. And so you may need to work with your primary care doctor to actually work on maybe cutting down the blood pressure medications a little bit if possible. If you elevate the head of your bed a bit or use a wedge pillow, that actually tricks your body's internal system and can make it so that during the day you have less of this issue. And there may be some consideration for medications that can actually raise your blood pressure a bit. One thing I'll warn people with these medications, if you're on them for raising blood pressure, is you want to avoid taking them right before bed, because if you lay down and your blood pressure skyrockets, it could put you at increased risk for other health problems. So you want to take it during the daytime hours, not right before bed if you're on one of these blood pressure increasing medications. People who have constipation, first, second, and third is still going to be fluids, dietary fiber, just day-to-day lifestyle stuff. If that doesn't do it, maybe a mild laxative scheduled or a mild stool softener scheduled. And if it's really becoming problematic, then it may be worthwhile seeing your primary care doctor or a GI specialist, a gastrointestinal specialist, to help with that. And then finally, I'll close with just some great informational resources. This is not an exhaustive list at all, but some of the national organizations that are reputable sources. There's a lot online that you can't trust. These are sources you can trust for more information, support groups, resources, new info on research, etc. I'll take any questions. So the question was, there's a small research paper that came out regarding a chemotherapy medication to try it on patients who had Parkinson's and I think memory problems as well, maybe. And it apparently in that small percentage in that small population may have had some benefit, and so they're looking more into that. But it's still very experimental, very small studies, so we have to see how that bears out. So is depression intrinsic to Parkinson's? Is it something that Parkinson's is causing? Or is it just that you can't move around as much, you've got Parkinson's and you're feeling kind of low and bummed out about that? Can be both, but definitely there is an intrinsic component. There's something about Parkinson's disease, the way it affects the chemicals in the brain, that can make people depressed regardless of the kind of how bummed out they are about the condition, how limited they are about the condition. Which is another reason that the movement symptoms may be great, but people can still be depressed despite that. So the question was, if you've already had deep brain stimulation surgery, would you consider trying the Rytari, the long-acting Sinemet, or trying the Duopa intestinal gel pump then on top of that, on top of the DBS? I don't have personal experience in that sense. I'm not sure, Dr. Chu, if you have further thoughts in that regard.
The new medications are really just reformulations of Sinemet. And we know that you can use Sinemet on top of deep brain stimulation. They just work, they're just absorbed differently. And so there's no reason to think that they can't be tried or that they wouldn't necessarily work. But they are very expensive. So it's one of those things that I think going in the future, if deep brain stimulation is not giving you the effect that you want, I think it's reasonable to consider trying these medications.
Okay. Yes?
My neurologist mentioned development of a patch system of medication delivery. Do you know anything about that? You haven't mentioned it here.
So we do have, currently there's something already, the dopamine agonists. There's something called rotigotine patch, which already exists, which is a dopamine agonist, one of the adjunctive agents that I mentioned, that is available in patch form. In terms of things like Sinemet patches or Sinemet gels, things like that, I think that there has been some research in that regard, but I'm not sure if there's been something that's currently on the market.
Yeah, so in terms of, there actually is in development a patch of Sinemet, of levodopa. Right now, I think the last I heard, it's this big, so it's really not practical. The patch that Dr. Snider was talking about is rotigotine. So rotigotine, it's also called Nupro, is the brand name, and it's similar in action to pramipexole, which is also Mirapex, or Rapinol Requip. So there's no reason to believe that it would act differently, but it's absorbed differently. Sometimes people respond differently to these medications.
Assuming with a sort of a more continuity as opposed to the up and down delivery.
Yeah, so theoretically, when it gets absorbed through the skin, it's more of a continuous absorption, but it depends. There are all sorts of factors that come into play. If you're a sweaty type person and you sweat the patch off, you're really not getting consistent absorption. And so I think it just depends on the person.
So for memory loss, and again, they'll talk a little bit more about that in detail in a future lecture, but the same medications, or a number of the same medications that we use for Alzheimer's disease, for example, or even for Lewy body dementia, can also be helpful potentially helpful in Parkinson's disease memory problems. So we sometimes will utilize those. We also kind of do other things, treat the depression, treat the sleep problems, make sure there's no vitamin deficiencies or thyroid problems, other contributors to the memory as well. But there are a number of medications that are used in other dementias that can be helpful for this as well. That's correct, yep. So the Azilect was, I mentioned the MAOBIs, the selegiline or sagiline. The brand name for one of those is Azilect. So that's under the category of the MAOBI inhibitors, which again can potentially be a good adjunctive agent. And again, the warning with those is A, they can be very expensive, and B, they're probably not as good as carbidopa, levodopa, Sinemet. So it can also, with selegiline, sometimes can be a little activating, give people a little pep, which sometimes can be nice, but sometimes can also interfere with sleep a little bit. So. The question was, protein and absorption of Sinemet, carbidopa, levodopa. In theory, that protein will decrease the absorption of the Sinemet, the carbidopa, levodopa. So for best absorption of it, they say don't eat protein around the time you're taking your medication. Again, it's a balancing act. If you take it with meals, you may have decreased side effects, or you may have decreased nausea, GI side effects. It may be absorbed a little bit better. So the question being, for patients who have hallucinations, what counts as dangerous? It's very case by case. Certainly, I mean, on one extreme is they are taking a stick and trying to hit the hallucinations. They're running at the hallucinations. They're punching at them. They're calling the police about the hallucinations. But there's also more subtle shades of gray that can also be bothersome. If they're having long conversations with these hallucinations in the middle of the night, or they're, the hallucinations are telling them bad advice or things like that. Which certainly can happen. I think it's very case by case, but certainly if it's getting bothersome, then it's something where I'd consider potentially treating. But it's very case by case, and it kind of just something you need to talk about with your neurologist specifically. But, can be both. So patients who have Parkinson's disease, who, for example, aren't on Sinemet, can absolutely get this, the drop in blood pressure upon standing. But Sinemet can also do the same thing. One thing we may gauge is, obviously, if we started this carbidopa, levodopa, the Sinemet, and all of a sudden they're getting more lightheaded, then we can say, well, the medication is probably, at this point, doing a large part of that, but they may also be predisposed to drops in blood pressure already. So the drop in blood pressure can be both due to the disease and the medications. And sometimes we're a little hamstrung in terms of prescribing the medications because we're worried it's going to cause further drops in blood pressure. And that's why it's important to be hydrated, to work on the salt, to lower blood pressure meds if needed, to give us, some, slightly selfishly in a sense, some more leeway in terms of increasing the medications further to better control the other symptoms. So that's why it's very important.
Familiar with Northera, which is droxidopa.
Yeah, the droxidopa. So that's one of the new, of the three medications we tend to use to bump up blood pressure. That's the newest of the three. It potentially could be very helpful. I haven't had a whole lot of experience using it yet. I've mainly been using the other two, the midodrine, the Florinef, but I think it's also a reasonable option. Things to consider for that medication: extremely, extremely expensive, so it's not our first line that we go to, but it could potentially be a useful option if you've really got refractory trouble with lightheadedness on standing blood pressure drops. So does, in what ways can Parkinson's affect vision and visual interpretation, such as reading? Probably a few different ways. People, it could be as simple as you don't blink as much, so your eyes are getting drier, so that could impact that. Sometimes people who have had Parkinson's for a while may have trouble with some visual, spatial interpretations. It can sometimes affect that as well. I think those are a couple things that come to mind. Dr. Chu, I'm not sure if there's any other. Yeah. Oh, yeah. So sometimes people with Parkinson's may have some trouble kind of getting their certain eye movements, particularly converging, such as when you're reading, maybe a little trouble with those eye movements over time. So that could also contribute as well. So yes, they're yeah, and it's one of those things where a few things could come together. Yep. So does the convergence, insufficiency, or similar issues, could that contribute to double vision? Potentially, although usually if there's concerns for double vision, I would probably say, I'd want you to check with your eye doctor to make sure there's nothing else going on there that could also be contributing to that. Anytime, with a little blurry vision here and there, it's always good to check with your eye doctor regardless. Double vision, I think, would be reasonable to definitely check with them, make sure that that's the explanation versus something else.
Yeah, you can have double vision with convergence insufficiency, but it's usually close up, because what happens is, as you hold a piece of paper close up and reading it, the eyes can't move together to focus on it. So if the double vision is just with reading, but far away vision is okay, then you can attribute the double vision to the convergence insufficiency. But if it's double vision no matter where you look or all the time, that's a different story. So again, this is a question about the chemotherapeutic drug nilotinib, which I'm actually not sure I'm pronouncing it right, whether or not there's going to be a clinical study or what's the likelihood. If it if they apply for funding and they are looking for sites to do it, we probably would apply to be a site to do that. I think we're probably looking at a few years out, though, before that happens.
So right now, we really don't have a way one way or the other to slow down that. So the question is, with the brain cell death, the death of the dopamine cells, the neurodegenerative process in this, are there ways we can help protect the brain cells? Right now, we don't have anything, and we've tried a lot of different studies that have not shown significant benefit. They're still looking at a number of studies to see what we can do. Again, I kind of pitch exercise as kind of the best thing we have right now to kind of keep things strong, but really we don't have great treatment right now to prevent the death of brain cells, the dopamine cells in the brain at this time. So there's no specific dietary, no studies that have, so the question is low-carb diet, is there any benefit there? And in general, there's no study that has shown benefit from a particular type of diet in Parkinson's disease. What I generally tell people is just eat a healthy diet, as best as possible. Well-balanced, healthy diet is probably your best bet in general. Because anytime if you're having an unhealthy diet and your cholesterol's up, your blood pressure's up, and if you had increased risk for other health problems down the road, that's just one more thing to worry about and one more thing that could affect the brain. So I just say healthy diet in general is the best we have, not a specific type of diet. Yep. It depends if he's awake at night. Is the big thing. Is because if someone's clearly asleep and they're acting out their dreams, that could be the REM sleep behavior disorder. If they're awake but it's nighttime, they're lying in bed and they're seeing things at night. They're seeing people or animals or shapes or things. Then that could be more nocturnal nighttime hallucinations. So just the timing of the day doesn't matter. It's more kind of the situation, is the person awake and asleep. Sometimes that can get muddled a little bit because it's hard to say sometimes if you're just waking up or if you're fully awake or if you're still asleep. But it's something you want to mention to your doctor if there is nighttime things that are being seen, particularly if there's concerns that it's getting disruptive or it's at all dangerous. So the question is, any loss of teeth, dentition problems as a result of Parkinson's disease? Nothing that immediately comes to mind for me aside from, if you're not swallowing as much, you have excessive drool, could you have more risk for cavities and such? It's kind of a smaller reason, but I'm not sure, Dr. Chu, if anything.
Yeah, so sometimes if it depends on how you're brushing your teeth, right? If your hand is not as coordinated, and you might not be able to get to some of the back teeth as well as you would if you didn't have those dexterity type problems, that can lead to cavities and lead to poor dentition. And then sometimes people, as the disease progresses, the mouth can hang open a little bit more. There's more drooling, leading to more dry mouth, and that can actually lead to more cavities and dental problems. So it may be a contributor. I don't know that that's going to be true for everyone who has Parkinson's disease.
So the question is, by the time you actually start to have symptoms of Parkinson's, you've already lost a lot of your dopamine-producing cells by that point. The disease had already been going on for a while. And that's something that we've, I think, really understood more and more, that you kind of have Parkinson's, in a sense, for many years before it gets bad enough that your body can't compensate anymore and that you start to show symptoms. And that's one of the reasons in research in particular, we're trying to find ways and working on ways to see early signs of Parkinson's earlier so that we can intervene before you've lost a huge number of the dopamine cells, to kind of get ahead of it as best we can, not when we're already very far along. By the time you manifest symptoms, the disease has been going on for many years, kind of invisibly in a sense. Okay, thank you very much.